Hi, my name is Caitlin Ireland, and I'm continuing the presentation on cannabis. Medical uses of cannabis. So it's been used for thousands of years to treat various different types of ailments. Doctors can also now prescribe medical marijuana in places like Canada and about half the United States. Trials were run to determine if cannabis meets the medical standards for safety, efficacy, and reliability. THC. It's an antiemetic, which is a drug that stops nausea and vomiting. Orally administered THC has been found to be more effective than the placebo. It also reduces severity, duration, and the number of episodes of chemotherapy-induced nausea and vomiting. There also are conflicting views about whether THC is more effective than the newer pharmaceutical, though, and an indirect comparison of the efficacies stated that newer pharmaceuticals alleviated nausea and vomiting in 90% of their patients, whereas THC only was able to control symptoms in about 30% of their patients. Patients also reported having side effects such as paranoid delusions, hallucinations, dysphoria, and cannabinoid hyperemesis syndrome, which is cyclic vomiting. North America and European oncology departments do not recommend this as a first line of treatment due to there being only about 30% of the patients being able to control their symptoms, and then also having all of these side effects along with that. Marinol, this is a drug derived from cannabis. It's approved for the treatment of cachexia, which is the general wasting and malnutrition that occurs in chronic diseases such as cancer and HIV or AIDS. In numerous double-blind, placebo-controlled studies, it supported the effectiveness of THC in increasing appetite, number of eating occasions, total food intake, weight gain, and stability over time. Compared to Megastraw, which is a commonly used pharmaceutical drug, THC is less effective in both promoting appetite and weight gain. So the effect of dependency. Patients with HIV or AIDS who have marijuana dependency demonstrate poor antiviral medication adherence and greater HIV symptoms and side effects compared to individuals who abstain from using marijuana. So for these individuals, the ones that have HIV and AIDS, it's better for them not to be dependent on marijuana because it can increase those HIV symptoms and side effects. For pain, the endocannabinoid system is involved with modulation of pain. Clinical trials were conducted to examine the efficacy of cannabinoids on various forms of pain. Results found that THC alleviates pain to roughly the same degree as a moderate dose of codeine. Authors do note, though, that there are short-term effects of using cannabis as a pain reliever, such as altered perception, motor function, and issues with cognition. Some reports stated that at high doses, marijuana may even increase responsivity to pain. So there's kind of like two sides of this. Yes, it may decrease those pain levels, but it can also increase the responsivity to pain. So there's like both sides of the coin there. It could be a positive or a negative depending on the situation. Muscle spasticity. It's disorganized sensorimotor control that leads to involuntary muscle activation. It can cause pain and sleep disturbance in disorders like MS or ALS. In patients with MS, THC outperformed the placebo in reducing spasm severity, frequency, related pain, sleep disruption, and urinary problems. Cannabinoids reduce spasticity through anti-inflammatory and neuron inhibitory actions with the spinal cord. A flex of marijuana only lasts for 3 hours, therefore it would be insufficient evidence to recommend THC to alleviate symptoms of ALS. So again, like it'd be better to find a different medication for things like ALS because they would have to smoke marijuana every 3 to 4 hours in order to get that effect. For glaucoma, it's a neurodegenerative eye disease. It's intraocular pressure is too high in your eye, and it causes damage to cells in retina and optic nerve, and it also may cause blindness. Marijuana reduces pressure within the eye for approximately 60 to 65% of individuals with glaucoma. The effects of marijuana, again, like I said, only last 3 to 4 hours. So individuals would have to smoke multiple times a day in order to get that relief that they want. So the North American Ophthalmology Society suggests that patients instead get surgery or other long-lasting treatments to improve that is proven effective, because again, they would have to smoke this marijuana every 3 to 4 hours in order to get the relief that they want. For epilepsy, there's conflicting results. Cannabinoids have been found to produce anticonvulsant effects and reduce seizure-related mortality. But then there's also evidence that suggests that cannabinoids can lower the threshold for seizures, and withdrawal from THC can cause increased susceptibility to convulsions. So depending on the patient, it can go either way. So there's mixed results there. CBD or other non-psychoactive cannabinoids may be most effective when treating seizure disorders, and due to conflicting evidence, a conclusion cannot be drawn regarding the use of cannabinoids in treating epilepsy or other seizure-related disorders. So other diseases or disorders, cannabinoids have been investigated for treating numerous disorders: Tourette syndrome, Parkinson's disease, Huntington's disease, mental illnesses such as anxiety, bipolar depression, cancerous tumors. The list goes on and on. There's so many diseases and disorders that are being tested and seeing if cannabinoids may help. Findings are inconclusive at this time, so more extensive research is needed for these various diseases. Synthocannabinoid compounds may contain anti-epileptic, anti-emetic, anti-cancer, anti-inflammatory, antioxidative, cardioprotective, and immune suppressive properties. So there are many good properties that are seen in cannabinoids, but again, more extensive research needs to be done in order to determine if it is a good treatment for these various diseases and disorders. The extent of cannabinoid use. So cannabis plants were grown in nearly every country in the world. 182 million people worldwide use cannabis, so that's approximately 3.9% of the world population. Prevalence of use among 15 to 64-year-olds in Americas is 8.4%, more popular in North America than in South America. For African countries, 7.5%. Oceania, so that's Australia and New Zealand, is 10.7%. Western and Central Europe is 5.7%, and Asia is 1.9%. Factors that may influence marijuana usage, so availability, social acceptability, and perceived risk of harm. Students in 8th through 12th grade stated that marijuana would be fairly easy or very easy to get, and I think a lot of us can agree with that when we were in middle and high school. It was fairly accessible. So social acceptability, trends in disapproval of experimental marijuana use are the lowest levels ever recorded, so that has decreased a lot. Perceived risk of harm. Students who believe that marijuana smoking posed a greater risk of harm are at an all-time low. And positive publicity and changing laws that allow adult possession of marijuana for both recreational and medicinal purposes increases accessibility and lead adolescents to believe that marijuana is not dangerous. Annual cannabis use. It's reached historic highs in the 1970s. About half of 12th graders reported having used marijuana at least once. People primarily smoked in groups, in a circle, passing around a pipe or a joint. It had the strong social reinforcement and feelings of shared pleasure and intimacy of the drug, and was responsible for high initiation and continuation of use. I thought this was a cute little gif here. I'm sure a lot of us have seen that 70s show, and that's a good example of when cannabis reached historic highs in the 70s. And here's a group of Eric and his friends, and they're around a circle, as you can see in a bunch of episodes, and they typically pass around joints and come up with, fun ideas. So historic lows in the 1990s, so it went down to about 22% from when it was about 50% in the 70s. There was a small peak in the mid-1990s to 38%, and then there was another decline in the early to mid-2000s, and then it rebounded again. Now rates have leveled off to 35 to 36%. Daily marijuana usage. For 10th graders, the number of people who use marijuana daily is higher than those who smoke cigarettes daily. Also, boys demonstrate higher marijuana usage than girls across all age levels, and rates of daily marijuana use have been gradually increased in 19 to 28-year-olds since 2006, when it was at an all-time low, and rates of daily marijuana usage has increased greatly for adults to 35 years old since the early to mid-1990s. So I thought this was like an interesting study about recreational versus daily usage individuals. So they determined that an effective dose of THC is 12 to 22 milligrams. Recreational users smoked about 10 days a month, while daily users smoked approximately 29 days a month, so basically every day of the month. Recreational users took 13 days to smoke an eighth of an ounce, and daily users did so in 3 days. The THC content of cannabis did not differ between these two groups, and the amount of cannabis plant material and subjective ratings of stoned were the same amongst the two groups. So I thought it was really interesting that even though it was comparative amongst recreational and daily usage, they have the same THC content, same amount of plant material, and same subjective rating of stoned. So I thought that was interesting that even though one person smokes about a third of the time as the another person, they still have the same grouping for those three categories. So there's my references. I hope you enjoyed my presentation, and I hope you enjoyed the rest of my group's presentations as well. Have a good day.